Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Well, hello and welcome back. I'm Dr. Adam Stryker, editor and host of Central Line. Today, another treat. We seem to have a nice line of treats here, but a treat for me because I know Dr. James Mesrobian very well, and he is our guest today. Dr. Mesrobian, a former executive at Team Health and former officer of the American Society of Anesthesiologists, is with me today for a discussion of the role of humanities and leadership in anesthesiology. I'm excited about the topic and the discussion. So, Dr. Mesrobian, welcome to the show.
Adam, it's really great to be here. I'm excited to just spend some time with you and get into this topic a little bit. Thank you for having me.
Absolutely. Now, obviously, I know you pretty well, but a lot of our listeners may not know you as well. Dr. Mesrobian, do you mind giving them just a little bit of background about yourself and your current role?
Sure, not at all. So I've been an anesthesiologist for over 30 years, always in clinical practice at that time, and been in a variety of settings, private practice a couple times, employed by the hospital system, vice chair in an academic department, and a couple times with Team Health, a large practice management company. I've been kind of blessed throughout my career to, by no particular design, find different leadership positions, seek them out, learn how to succeed or not succeed in them in all those stops. And then the last thing I'll mention, Adam, which we'll get into a little bit later, is yes, I am a former humanities major. I majored in college in philosophy, and we'll talk, I think, a little bit about how that might have informed my leadership and how that more broadly might be important for physician leaders.
Perfect segue. Let's delve right into it because I do want to talk about humanities mainly throughout this discussion. And obviously, you have a strong background in it. We're all clinicians. The clinicians are mainly listening to the podcast. I know you feel strongly that humanities can help us as clinicians and leaders. Talk a little bit about why that is the case.
Yeah, I'm happy to. And I want to be real clear up front. I am not suggesting that if anyone goes and reads a book or watches a piece of artwork or listens to music, they're going to automatically become insightful, smart, and perhaps better at relationships than they used to be. But what I am going to probably say to you is a little bit around how those practices and that study of the humanities can develop you as a leader and can contribute, not by itself, but alongside other development tools to developing executive skill set. I would back up to this by saying basically, to be an effective physician leader, yes, you have to have excellent clinical judgment and business acumen, but you also have to have some other things. You have to have broader skills, as with any leader, around deeper self-awareness, empathy, and ability to read people, among other things, what we typically refer to, Adam, as the social skills. And yet one of the problems I discerned throughout my career, having received some professional development education, was that current executive development often focuses on technical expertise or business health management, for lack of a better word. Yet the most likely reasons for executive failure, if you're a leader, or underperformance, really aren't technical, financial, or administrative. They're more likely lack of relational skills. It's interesting, there's an article in the Harvard Business Review from 2022. It's titled "The C-Suite Skills That Matter Most." It was published in the July-August issue that year. And the authors looked back over 20 years, from 2000 to 2020, as to how many ads for CEOs were focused on social skills and how many on technical skills. And what's fascinating over that time is that the ads for social skills climbed and climbed and climbed, yet for technical skills declined as something desired in the ad. So there's a recognition that these social soft skills, as we like to put them, are critically important to your success as a CEO. And yet in healthcare, they don't seem to have really taken root as something we commonly look for. The other thing I'd add, Adam, just as a precursor, what do we mean when we say social skills? Well, we'll talk about that in a little bit, what that means. But I want to be clear, we're not talking about cliches or pithy concepts, pop psychology, or some of the motivational phrases you often hear. And I've stepped in this before. I definitely am not talking about anyone who majored in the hard sciences somehow not knowing how to think. That is not where I want to go today. I've gotten in trouble with that before. And what I really want to focus on is why the humanities can help you become an executive with a stronger leadership skill set. When you consider the skills great leaders possess, they're typically broader and deeper than just kind of self-awareness, which is typically how we define emotional intelligence. Self-awareness, yes, is critical, yet also the ability to critically think, distilling complex concepts to plain and clear speech, oral communication, written communication, building and leading teams, judgment and problem solving, inference or reading the room, and then lastly, making decisions. So if I had one underlying rationale today, it would be your technical, administrative, and financial skills absolutely matter. Yet as a leader, your social competencies are more likely to impact your success and performance, and the close study of the humanities can strengthen those social competencies.
Okay, well, want to cover all this. Let's start by narrowing in a little bit and then starting to zoom out to get a better sense for the humanities overall as an aid and an adjunct to the practice of medicine and leadership specifically. So narrowing in, talk a little bit about your personal story in how humanities has helped you in your career. And then after that, we'll start zooming out and trying to apply it to the broader landscape.
Sure. Let me start by saying in leadership roles over the past 15 to 20 years, I've skinned my knees plenty of times. And the majority of times I've done that was when I didn't recognize what other people were thinking, what the situation was in the room or meeting I was in, or what the relationship was with an individual. Let me give you a very concrete example and explain how I kind of over years worked myself out of that. When I was new to practice, 5 years into practice, a good clinician, reliable, showed up on time, my private practice, along with the hospital, decided to create a new position called professional director. The task of this position was loosely defined as serve as the liaison between the hospital and the large group. So I got appointed to this position with no mentorship, but also, frankly, no grounding in the skills I needed to succeed. I had been in those situations where I needed to develop self-awareness, how to build a team, how to recognize differing priorities or values. And that was a position that ultimately was dissolved a year and a half later with my really having done very little in it. And it's bothered me to this day and prompted me since that time to really think about that skill set that goes into executive development. I'm going to fast forward now a little bit to about 8 years ago. There was an article in the Wall Street Journal written by 2 professors, I believe at Penn State. And the title of the article was, "Doctors Don't Need English Majors." And the 2 authors basically went on to state that it is a wasted time for physicians in the US to go to undergraduate education. They certainly don't need to major in the humanities, and all this does is add cost to medical education. So I did something I'd never done. I wrote a letter to the editor, and it's the first time in my life I ever got published in a national journal. They published my letter to the Wall Street Journal. And what I said at the time was, well, I understand their position around cost. I strongly disagree that exposure to undergraduate education, and particularly humanities, is not valuable for physicians. I've used that skill set around slowing down and thinking and discerning and really listening to what's being said to me multiple times in my career, and I can't imagine working without it. And that was probably, to your point, Adam, the first time I was forced to sit and say, why did the humanities, why did that seed planted when I was a philosophy major kind of start to make me listen a little differently, ask questions a little differently? And it only came out later in my career after I'd had time to frankly practice it and discover it a little bit.
Now let's zoom out a little bit and elaborate on just what you were talking about with regard to the letter to the editor and medical school education. Do you feel that we're doing enough in medical school education? If so, why? If not, how much more and why? And let's start there, just on the educational piece.
Absolutely. So I think the answer to your question is twofold. It's yes, we're doing more, but we're probably not doing it consistently. So the first medical humanities program in the US was founded in a medical school in the 1970s. And by the early 2000s, approximately 3/4 of US medical schools offered some sort of medical humanity training. And typically for physicians in medical school or near physicians, that training focuses on developing empathy and perhaps kindness and a focus on the patient. It's very much an affective training. And indeed, even the undergraduates took up this. In 2021, there were about 120 undergraduate programs in medical humanities. So these have grown over decades and become more of a standard curriculum. The other side of that is that they're not really required or consistent. And there's a study done in 2023, a survey of 31 top-ranked medical schools about their medical humanities offerings. And what they found was a couple things. One is that the majority of the curriculum focused on empathy rather than shaping and expanding how you develop knowledge or how you assimilate information. It was more about affect than effect, for lack of a better word. The survey also revealed that there was a lot of inconsistency. A lot of places offered over 10 humanities events a year. 52% had a center, 70% had 5 faculty or more, 68% had over 5 student organizations. Yet here's the kicker. Less than 10% of the schools required the instruction in the humanities. So I think that's an area to improve. It's there, but it's inconsistent. I would also point out that the American Association of Medical Colleges in 2020 published a framework around the fundamental role of arts and humanities in medical education. And they basically laid out the rationale that medicine is an art as well as a science. And they promoted and requested further attention paid to integrative learning models around art and humanities, art and humanity-based professional development models, and art and humanity-based professional development education, among other things. So again, I think it's fair to say there's been progress, but it's inconsistent to date.
It's almost like an interesting dichotomy is created in that when we went to medical school in the years following, there seemed to be more emphasis on medical school admissions that had background in undergraduate education that were not science-based. And the dichotomy being that now the push, obviously, as you highlighted, from certain individuals that why do our physicians need this? And I'm pointing this out because I think it's, as you mentioned, and let's talk about that, the concept that we're all familiar with, which is the idea that the practice of medicine is a melding of art and science. So given that potential dichotomy, that different way of thinking, what we as society think we want out of our doctors, what we as physicians want out of our own practices, let's start there. Practice of medicine being art and science. How do you specifically see that melding? How does humanities help that? And how can we as physicians benefit from that relationship?
Yeah, I appreciate that question. And that phrase, management is art and science has been around a long time, probably, over 50 years. I think we have to be a little careful with it. Sometimes you hear that used in your day-to-day setting, and it's often used to describe when someone got lucky with a good management decision or to ascribe some sort of, guru status to someone who seems to see things differently than everyone else. I think an important point to recognize is this concept of overlap between art and science goes back decades. And there's a very good article, again, published in Harvard Business Review in 1975 by Henry Bettinger. And he wrote an article titled, "Is Management Really an Art?" And he described the similarities in it with a resounding yes between artists and managers. And I'll describe a little bit what he said. He basically said both individuals need to have 3 elements to be successful: vision, communication, and craft. So you have to be able to know your art or your medicine. That's the craft. You have to be able to communicate in a way that's clear to audiences of different types. And most importantly, you need to have a vision kind of outlining what you're trying to accomplish and what you're trying to get the viewer or the listener or the colleague to understand. And here's where he broke it down a little bit. He said, management science is really about analyzing problems in isolation and developing an independent solution for each one. And he said management arts is around synthesis. It's about taking isolated ideas or problems and developing a connected solution, whether it's a piece of art or a solution at your workplace. And he went on to say art creates a vision of the whole, combining separate ideas into a common thread. And these are common skills also with great managers. He also said, think of it this way. if you have vision and no skills, we refer to you as a dreamer. If you have skills with no vision, we refer to you as a technician. If you can communicate without any ideas, we call you a hack. And same applies to artists. Bettinger said, at the end of the day, both artists and managers need to know that effective communication isn't just about clarity. It's about how you help others see what you see in the sequence and framing that makes acceptance possible. Think about that concept, whether you're leading a group of physicians or you're a clinical frontline physician working with nurses and trying to explain to patients. In the 80s, Peter Drucker also described this need. And I think most people on this podcast will know who Peter Drucker is, long regarded as the father of management science. And he also ascribed to what management is basically a tradition that we used to call liberal art, because it deals with the fundamentals of knowledge, self-knowledge, wisdom, and leadership. And managers draw on all knowledges and insights of the humanities and social sciences, psychology, philosophy, economics and history, and ethics, as well as on the physical sciences to be successful. So there's this recognition going back decades that the way you think when you're digesting a social science is very applicable to your success and your ability to synthesize different information as a physician leader. So I think that's kind of the connection I'd make up front, Adam, regarding those two things. But there's also a lot of information in the neuroscience world around this too.
Well, let's talk about that. How does the neuroscience come in with how we reason and how we integrate the humanities?
Yeah, I'm glad you asked. Let me give you a high-level view of this. Another way to think about this concept is when you're a physician leader, how do you really make good decisions? What is your process for rational thinking? Do you question your assumptions? And I think you have to accept a couple things, that reasoning, your judgment, your ability to make good decisions starts with information, something you're given, and ends with a conclusion, a decision you make. So in the world of neuroscience, 30 years ago, psychologists believed typically that human reasoning depended on some formal rules of inference. Think of basic logic. If A, then B. If I'm presented with A, I'm going to conclude B. Kind of like a logic problem. Over the last 30 years, it's been realized that reasoning is a much more complex process that's much more consistent with what happens when you read great books or observe art. And let me explain. This view, reasoning depends on envisioning possibilities consistent with what you've been given. You're not looking at one possibility, you're looking at multiple based on a set of assertions, the inferences you're making. You construct mental models for different possibilities and derive a conclusion from each of them. But it doesn't end there. There will be errors in how you're inferring and errors in how you're concluding things. And in your brain, your ability to generate counterexamples to refute the wrong inferences. And that's basically the foundation for making good decisions, ruling out the things that don't make sense and eventually honing in on a conclusion that does. And it's our unique ability to create counterexamples to weed out bad inferences that allows us to do that. And you're probably going to say, well, all right, Jay, that all sounds good, but show me why that's actually valid. So there's research by a scientist named Mary Helen Immordino-Yang into an area of the brain called the default mode network. And it's really groundbreaking research. What she found in this area of the brain was that when people engage in what she calls transcendent thinking, so reflection on abstract or system-level concepts, or contemplating ethical implications of decision-making, they activate the same neural networks, the DMN, that are involved in self-awareness, moral reasoning, and identity formation. Further research revealed this network, the DMN, active during rest or when you're in deep observation and reflection, also plays crucial roles in moral decision-making, future planning, and understanding others' mental states. So there's also evidence growing in neuroscience that there's a strong connection between the brain, the DMN, its activation through the study of humanities, and connection to the same areas of the brain in which you exercise executive attributes. A last way you might frame this is that, the neuroscience would make a distinction between education and development. Education would be described as simply the transfer of knowledge, and this is what, frankly, a lot of us got in medical school. Rote memory, drive it into you, regurgitate it on the test. Development is much deeper. It involves utilizing that area such as the DMN to understand perspectives, navigating ambiguity and value conflict, and in real time, your brain adapting to reflect assessment of different possibilities. So meaningful learning and development really involves integration of both cognitive and also emotional processes in a way that's much more complex than just simple education and absorption of facts. And that's the way in which study the humanities, again, periods of discernment, reflection, trying to resolve ambiguity, really aren't luxuries, but they're neurobiological necessities for imagination, synthesis, and practical wisdom.
Well, and perhaps that's why I think people that aren't engaged in this level of healthcare may not quite understand that. I think to the layperson, you know, being a doctor, and a lot of us have were trained this way in science, basic science, and then in medical school, involves diagnostics and the answer being the treatment for whatever problem is diagnosed, i.e., your doctor needs to just know that because I just want a doctor that knows those things. That's all that's necessary. But it completely ignores the broader understanding that is necessary to actually treat patients, which involves not here's the problem, here's the answer. It is so much more complicated. And also being deferential to the needs of your patients, which is a lot grayer of an area, i.e., a treatment may cause other issues. The lack of a treatment may be an option based on what your patients want. What you're describing, all the research and the neuroscience and reasoning, gets to the heart of why there seems to perhaps be a misunderstanding of what physicians and other clinicians really do need to possess to appropriately and effectively treat their patients.
Yeah, I think there are two things here, and they overlap. One, we're talking about frontline clinicians and how you're looking at your patient, how you're listening to them, how you're understanding them. Are you really treating them well? And there's a lot of risk there, right? Clinicians are under enormous stress today. And some will argue, rightfully, I don't have time to slow down in the way you're asking me to slow down. But the other part of it, I would suggest, Adam, is, how we identify physicians as leaders. Remember the story I told about when I got appointed to being a professional director? I had no relational skill set to speak of in that realm. They chose me because I had great technical knowledge. I was good, precise, I was objective, gave a great anesthetic. But the reality is that's a mistake. You confuse technical knowledge for wisdom, and you confuse clinical skill for the ability to lead individuals. So that humanistic piece is absolutely essential. And like we said before, I'm glad that there's more penetration of humanities education in medical school. But when you get past that, it's hard to find. It's certainly not going to be probably found time for in residency. And later in your career and much professional development, it's hard to find it integrated into there as well. So there's a gap, and it's probably a critical gap in how we're really preparing physicians to be leaders. And I think that's what we're trying to address here.
So then give us some examples, if you have any, about how humanities have actually helped healthcare leaders make better decisions. And have you seen any of this out in the wild, if you will?
Yeah, I would say to you this. As with any intervention, it's almost hard to draw a straight line between the intervention or education and I'm a better leader or making better decisions. You probably can't do it with any part of executive education, finance, operations, administrative, or humanities. Yet I think you do see the impact of this upon skill development and use. And let me explain a couple ways. There are a couple programs that are strongly based around visual observation of artwork. One is called Artful Persuasion, where people are required to look at different pieces of artwork and talk with their colleagues about why they're seeing things differently, with the idea being that will translate into the field or the work setting in a way that allows you to understand the perspective of others better. There's a wonderful doctor in Brown University named Fred Schiffman, hematologist, who for years has run a program called Cops and Docs, where he takes policemen and physicians down to the Rhode Island Museum of Art and does the same thing with them, walks them through artwork, helps them to understand what they're seeing in a simple painting that's probably not available at first visual or first blush. It's a good way to train.
And I think I'd segue there to literature.
When I started getting back into reading literature and understanding great novels and great philosophy, it slowed me down. When you really read something closely to absorb it, it makes you slow down and try to concentrate word by word on what the author is saying, focusing on the relationships in the book, recognizing when people have conflicting values or motives that aren't aligned. Great books help you recognize when values are in conflict, when morals are compromised, and relationships are poorly defined. And those are the things you need to do as an executive leader. So I can't point you to any outcomes data. I think you could find plenty of examples of people who have done this and said, whether it's through art or others or through reading or music, I've been forced to slow down and activate that part of the brain that is involved in the executive skill set. Let me give you a concrete example book-wise, because it's a little vague. When you talk about reading about Aristotle on virtues, it really makes you think about, how am I behaving? How am I making decisions? It's a framework for how you think and act. But so also is reading really one of George Orwell's least understood and least known books. It's called Down and Out in Paris and London. And it's when he spent time as a young man in the 30s, very poor in those two cities. And he talks at length in great detail about who he worked with and what they were like, and how sometimes they were in conflict with each other at the workplace, other times they weren't. It's a remarkable book because you come away from it saying, if he could observe that strongly people he was working with in the basement of a restaurant in 1930s Paris, why am I so challenged to do the same thing at work and understand who I'm working with? So I think a lot of the development is personal, and the outcomes tend to be very much self-awareness and self-discovery.
Well, let's talk barriers. What specific barriers do you see that exist in preventing our clinicians and leaders, or clinicians that aspire to be leaders, from gaining the humanities education or exposure or experience that they might like or need?
The biggest barrier is probably time and habit. Boy, we are so busy every day, whether you are clinical, administrative leadership, or a little bit of both. There are days you feel like you're checking off a box. There are days your emails extend into the evening, and there's always this subtle pressure on weekends to be catching up on your work. And how often do any of us really take time off to sit, to read, to rest our brain, and really kind of think abstractly about the organization I'm in, or how I'm managing the people who work with me and underneath me? I think the other barriers outside of that general one are what I said before. Internally, we tend to overvalue technical knowledge. We think that physicians who are really good at clinical work will make good leaders, and that may be true, it may not. I think there are also some external barriers that perhaps are more easily addressed. You still hear occasionally, and it tends to be cyclical, that the humanities are irrelevant to job and career advancement. And as you probably guessed from this podcast, Adam, I'm strongly in disagreement with that statement. There are enormous benefits to understanding how to really distill knowledge that will benefit you later on. But the phrase that was stated about 10 years ago, well, you better be in STEM or you're not going to get a job, did some damage. And I think only now the humanity majors are recovering. Some would say it's irrelevant to a tech-oriented world. Some would say, healthcare is different now. Gone are the days where the CEO would just walk down and talk to his board and talk to his physicians and talk to the people and be more of a social manager. But I would argue to the opposite. It's a mistake to say it's not necessary now just because we are in a very technology-driven world. In fact, as hospital systems get bigger and bigger, the role of being a leader becomes less personal and more decentralized. And you're often interacting with people you may never see or see very rarely in a room. I think that decentralization, that more and more use of technology, kind of conversely makes it more of a necessity that we develop these type of humanistic skills that allow us to better interact with others, understand others, and manage others. So I think the barriers are part internal and part external. I think we have to rethink a little bit what your priorities are if you're in a leadership role. You have to rethink, am I taking time off to really think hard and deeply about what I'm doing here, or am I scrambling every day? And I think the same thing applies in the clinical frontline worker as well.
Let's say you do have someone in that position that you just described, and they're listening to this podcast and they're reflecting and saying, okay, this makes a lot of sense to me. How do I know I'm taking enough time or doing the right things, even if I spend some time thinking about my larger role and how I'm managing the people under me? What does it ultimately mean? Am I doing the right things? What would you, I guess, A, say to that person on how to self-assess, and then B, what are some suggestions for them and then others listening on where they might start or go to pursue some more understanding of what we're talking about?
Yeah, it's a great question, and it's not one with an easy answer. Because I think the first thing any physician in a leadership role, and in a sense we all are, would do is there's a phrase that's coined by Father Richard Rohr. He's a Franciscan priest in New Mexico who runs a large organization out there, and he calls it discharging your inner soldier. And he uses that for when you're transitioning from a phase of life to another phase of life as a way of stopping to doing things you've always done, whether it's behaviors, time management, actions. And I think that applies to physician leaders too. We have been so, as you pointed out in our education, ingrained in learning, precision, getting diagnosis, taking care of the next patient. You know as well as anyone how strong the operational pressures now. And there just comes a time where you have to say, you know what, that's not what I'm all about. So you're discharging, you're not completely discharging that part of it, but some point during the week or during your workday, you have to be able to get out of that mindset and get into a more contemplative and reflective mindset. I think there are things individuals can do. One useful framework I've spoken about with some clinicians is if you think about emotional intelligence, your self-awareness and understanding others as the muscle, you want to use the humanities to exercise the muscle. You want to read a book and devote time to do it. You want to listen to music. You might join a creative endeavor or club. People join book clubs so they can just think differently. One thing I used to do was integrate humanities into a meeting. I'd start a meeting. I'd ask if anyone read a good book, saw a good movie, and we'd talk about it for 5 minutes. It was a nice way to kind of level set a little differently from diving right into the technical part of the meeting. But the thing I'd leave you with is you have to exercise this muscle called EI. And the way you exercise it is through strengthening in your brain, through the humanities, what you're thinking about, how you're thinking about it, and how you're making decisions. And it's really supported by both, I think, practical wisdom and by neuroscience. And the last thing I'd say, if anyone said, you are wasting my time, doctor, don't tell me this, I'd say, you know what? This is a critical skill set for you, and this is one way to help develop it. The other thing I'd say is, it'll be fun. You'll turn over some new earth in your head and you'll enjoy it, especially if you find something you like doing. So I'd leave someone with those two thoughts, Adam, as to barriers and how you get out of it.
Well, Dr. Mesrobian, thank you. This has been an incredibly insightful discussion, and your experience and insight is so invaluable. I'd love to keep talking about this for hours and hours because it's such an interesting topic, but I just want to thank you for your time and sharing all your thoughts on the podcast.
It's a pleasure to be here, and thank you for having me anytime.
And for our listeners, I hope you've enjoyed this episode of Central Line. Please make sure to tune in again next episode and take care. Thank you.
Hello, ASA. I'm Dr. Patrick Guillaume, your ASA president, and this is the Monday Morning Minute. First, several state-level wins are tied to ASA's partnerships with our state component societies, including no new opt-out states, affirmation of anesthesiologist-led care, and Oregon and Utah enacting laws preventing insurer anesthesia time limits. Next, National Women's Health Week was May 10th through 16th. Our active support included the ASA Monitor article, Physician Health is a Workforce Imperative, authored by several members of our Committee on Women Anesthesiologists. And CWA member Dr. Jeanette McVeigh recorded a video about how anesthesiologists care for mothers during labor and delivery. And last, ASA representatives met with staff leading the Trump administration's new Great American Recovery Initiative to discuss opportunities for collaboration in addressing substance use disorder and advancing safer pain care. Well, that's it for now, and I hope you'll follow us on your favorite social media channels and check out my weekly Monday morning outreach.
For more detailed and timely information, don't miss Dr. Guillaume's Monday morning outreach email delivered exclusively to ASA members' inboxes every Monday at 5 a.m. Eastern. Cultural competence is a key component to ensuring equitable healthcare. Explore ASA's Enhancing Patient Communications program to learn how anesthesiologists can better provide culturally competent care, and for tips on how you can communicate more effectively with patients in the limited time you have with them to ensure better patient care. ASA members take this course free. Visit asahq.org/EPCP. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.